here in Indonesia, in Bali first, and it's my first time here. It's a long flight from Brazil to here. It's across the world, literally. It's almost 30 hours traveling to be here. But I'm very happy to become, mainly because I saw today the entire society talking about the future, and there is no other activities during the event when you're talking about your future. It's not happening in Brazil anymore. When you're talking about the future, there is just a few enthusiastic surgeons on the audience. We talking about the future, but most of the colleagues doesn't in the audience anymore. We are something like 3,000 maxillofacial surgeons in Brazil, and when you talk about our future, we just 200 or 300. So 10% of the colleagues are really concerned about what's happening in the future. So this is the main observation I did today. So I'm very happy to you guys. Congratulations for that. So my first class today, or my activity today, is like talking about orthognatic surgery and what we're doing now when I treat the patient with deformities. I have no conflict of interest. My clinic in Brazil is the Vita Institute. We are a clinic with almost 80 doctors. Maxillofacial surgery, we are 7, and there is a lot of traumatologists. We are very specialized in musculoskeletal procedures, in orthopedics and maxillofacial surgery. My main job in education field is in the Sírio-Libanês hospital, when I have students for master degree and master in science in PhD. Also, I work in 2 other hospitals, the German hospital and the Moriá. They are very good hospitals also in São Paulo city. And São Paulo have a different dynamics. We use a lot of insurance of the patients. I do not work with the government anymore. I still work with them for almost 20 years, and I was in the army, and after that in the public health. But nowadays I'm just in the private. Brazil also is a tropical country. We have a very beautiful views over there, nice beaches. Danny went with us a few years ago, and it was a pleasant time. We have my colleagues here. You work in a very happy environment, and I'm sure if you have opportunity to go to Brazil, you will really enjoy. When we're talking about orthognatic surgery, we also looking for something. Of course, occlusion, of course, a better function, but there is a procedure we always change the face and looking for a better view or a beauty in our patients. The question is, what kind of beauty you're looking for? You're looking for your impression of beauty, or you're looking for their impression of beauty? Because we have a different impressions, we have a different opinions about what is beautiful or what is not. So the most important thing is always looking for what your patient wanted. One of the things I do in my office, I ask for the patient bring to me photographs about people he or she looks beautiful. So I asking for the patient, please you bring to me next opportunity. You can bring to me some pictures about how many women you think are beautiful and what you think exactly beautiful on them. So the nose, the chin, or the mandible contour, or the eyes. So then I can explain to the patients, well, this is possible and this is not. When you're looking for better performance in orthognatic surgery, we must to think about what we can do for the patient and what we cannot do. So the main concern is everything everything always about the patient, and listen to them. Listen every time what the patient have to talk to you. My first question always is, how can I help you? Why you are here? How can I help you? This is very important. So when I remember when I started to do orthognatic surgery in 1996, 1997, the first Brazilians are going back from the Dallas, United States, and start a democratization of the orthognatic surgeries in Brazil. Because until that time, it's only a few doctors in Brazil, they are doing orthognatics, but it's not so easy to learn. So the first Brazilians go to the Dallas with Dr. Ellis and Dr. Sim, and then they go back to Brazil and start to teach the residents and how to do orthognatic surgery. And at the time, are very difficult to reach a good stability of the fixation, mainly in the Le4-1 and also in the mandible as well. But anyway, the most important thing after so many years is how we can manage our fixation and how we can reach a stabilization of that kind of fixation. So like in trauma, like in reconstruction, we can do a lot of things in orthognatics, but we can do because we can have a good stability in our fixation. So, and we choose a plate to do BSSO fixation. We're looking for a rigid plate, we're looking for a thick plate, thicker, or bicortical screws, just screws. To tell you the truth, doesn't matter so much. The most important thing is neutralize the action of the muscular forces. So this is very important. Also give time to the bone healing, because how much stable you have, better stability is more time to the healing of the bone. Of course, the patient can have a lot of comfort because they don't have to use MMF in post-operation. If you have a good stability, you'll not have infection. So this is very nice as well. And then, when you have all these items together, you come more and more courage to looking for different kinds of movements. It's like, you know, you have more ability, but you have more, I don't remember the words in English, it's more courage, more great movements, huge movements. You're able to do that because you believe in your stabilization. So never forget, you must be looking for a bone contact. This is very important. And if you don't have, you can use a bone graft as well. Why use so light plates or so thickness plates in orthognatic surgery, and we're looking for the trauma surgery? We use so many huge plates, and we're looking for all the time load bearing, small fractures. Sometimes we use 2 plates, bicortical screws, and then we go to the orthognatics. We just use small plates, monocortical screws, and we have the idea that is enough. Well, the patient we used to do orthognatic procedures, they are patients, they really don't have good reduction, because the goal is change the position of the bones, right? Including the fracture or the osteotomy doesn't produce a simple fracture. The osteotomy is a very complex fracture, mainly in the mandible, and change the position. So it's not so good at all to use the load sharing. Also, we don't have lightly muscular strain, because the patient have a lot of forces. Normally, usually are very young patients, strong. They like to eat meat, chicken, and it's not so easy to control the diet after the procedure. But also they have a very good quality of the bone because they are healthy. They also have the teeth. Most of the patients have a very good occlusion in the end of their orthognatic procedures. That occlusion is stable. This is very important also. And the patient normally is a very cooperative, so they can go back to the office every single week. We can see him, we can change something, we can use elastics. So we have a privilege to have a very cooperative patient. So it is not a stable fixation. This is a fixation with a wrong plate in the wrong position. Maybe it's the wrong osteotomy. So the future for this patient is very poor in the shadows because probably she have infection, probably she have a bad union, maybe a pseudarthrosis. And you ask me, maybe doctor, how kind of fixation you prefer? Doesn't matter. The most important thing, you can use different kinds of fixation, depends on your patient needs. So if you usually use screws, that's okay, no problems. It's very strong fixation. You're just looking for a few facts happens with the screws, interfragmentary screws. So if you're gonna use the bicortical screws, never use the compression, use the positional screws. If you like to use a hybrid technique like I prefer, you can use one plate and one or two more screws. It's very strong fixation. It's very good for the condyle. So I believe you can use as well. And you can use also 2 plates. So it depends on the patient, kind of movements you're going to do, and the patient, depends on who is your patient, how strong is enough your muscles, and how cooperative he is. So we start talking about class 2 patients. Please, if you have any questions, interrupt me any moment, because I'm going to start to show a few cases to you in different situations. And it's very nice if you have any questions and you can ask me to me. Please come to the microphones and do your questions. So the patients class 2 always have almost the same concern. They have the concern about the gum smile. They have the concern, of course, without projection of the chin or of the mandible. And most of them have a lot of support of the lips, the superior lips. And if you do something wrong, the patient is going to be 25 years, 35 years, 45 years, 55 years old. And then if you put the maxilla backwards or in an upper position, you doesn't have the support of the lips in the oldest time. So remember, we hope the patient is going to be older also. And if you're going to do a very huge advance of the mandible with a clockwise rotation, is counterclockwise rotation, must you use a very strong fixation for the kind of the patients. I'm going to show you why I use virtual planning for 100% of my patients. Like I told you, many years ago, we have a few doctors in Brazil doing their orthognatics, mainly because the planning are very difficult at the time, really difficult. I try to understand how the older guys do the planning, and I never can really understood. So nowadays with the virtual planning, I can have the entire understand about the prediction of the surgery, the accuracy of the procedure, so it's much better than before. So remember, in clinical evaluation, it's very important to looking for where is my line and where will be after the surgery. Also, here is very important, the mandible contour. So the mandible contour in the end of the surgery give to the patient the really the notion of the beauty, the impression of the beauty. And the class 2 patient, mainly in the class 2 patient, we must be looking for about the TMJ disorders. Some patients have displacement of the disc. We're going to talk about this on a Saturday morning. But the main problem is if the patient have bad function. Maybe if the patient have bad function, you must be looking for take care about the remodeling of the condyle after the surgery. So never neglect how important is the evaluation about the TMJ in orthognatic patients, mainly in the class 2. And also the correction of the yaw is going to be a very, very important ask to you to provide a better results for your patient. I'm going to show you guys. Well, let me show you the patient. Here's a very young patient. She's a Brazilian girl. She's from the south of Brazil. She is doctor student for medicine. And she comes to me to looking for a better projection of the chin and a better contour of the mandible. But also, I believe she have a small area in the lower third of the face. So this is important because we're gonna change a little your face in the end of the surgery. So unfortunately, she doesn't have so many distance between the upper tooth and the lower tooth. So I can have the possibility to put the mandible so many forward. So what can I do for her? I can change the maxilla a little bit. So using the counterclockwise rotation also, and then I put the mandible a little bit forward and the chin a little bit forward as well. But it's very important to me. When I look at the patients in this view, in the axial view, I can see the mandible very clear, and I can see any kind of asymmetry the mandible can show. In the end of the surgery, I also can feel the same. So if you look at here, you can see the posterior spine of the maxilla, and you can see before is more on the middle. In the end, I improve a lot, not so a lot, but a few rotation of the yaw. This rotation is very important because she had, in the end of the surgery, a very nice contour of the mandible. So this is the first tip for you guys. Use the rotation of the yaw to improve the better contour of the mandible. Here's the pre-ops, the occlusion pre-ops, and the post-operative picture and x-rays. I use a hybrid technique with screws and plates. The left forward is the classic, and also the chin osteotomy. So here is she pre-ops and post-operative photograph, and here 1 year later. And also I believe the better results happens something like 9 months after surgery or a year after the surgery. Every time the patient asks me, how many times I must wait to the final results? And I always said a year, maybe 9 months, because the patient looking for results next week or next month, it is almost impossible, right? Here's another patient. She looks like very nice for me. She doesn't have so many class 2 looking in this view. Then when we go to the profile without the skin, we can see a huge asymmetry of the mandible. The work is the same. I put the maxilla forward, the back of the maxilla is going down, like a counterclockwise rotation, so I can put the maxilla forward a little bit and the chin as well. So when I look in here, look this view. Look how asymmetric is the mandible prior to surgery. So this is very dangerous because you just have only the advance of the maxilla and the mandible. You can have in the final surgery, in the end of the surgery, a very asymmetry of the mandible for her. So in the casts, when you use the casts, you know, must if you use the platform, it doesn't matter how good you are in the cephalometry, it doesn't matter how good you are when we think about the patient in the future. If you use the virtual planning, you're going to show something to you you never saw before. So this is very important. And looking here, how huge was the rotation of the yaw. So changing the yaw of the maxilla, I can change also the symmetry of the mandible, and the result's going to be more predictable. Here is the patient pre-ops, a month later, and post-op. At the time, I have an idea to ask for the patient's photographs more natural, because you always go to the clinic and we do that photographs of the black background in the same way, and I want to do something new and asking for the patient's natural photographs. You're going to see a lot of them. So this is another patient, almost impossible to change the occlusion, right? But when I looked for her, she had a few problems. First of all, gum smile. Second of all, just a few projection of the chin. But if I do so much changes in his profile, maybe she doesn't good. She's not become good in the end. So this is the planning. I put the maxilla in upper position a little bit. I changed the plan of the occlusion, so it's a counterclockwise rotation. And almost the patient, I'm looking for something less, -8, -9, -6, depends on how much the molars the patient will show you in the clinical evaluation. And of course, when I change that kind of things, put the maxilla up, counterclockwise rotation, I have a few space to advance the mandible a little bit. So this is the result. When I look in the axial view, one more time, I must use the change of the yaw or the change of the position of the occlusion just to looking for a better symmetry for the mandible. Let me ask you something to you guys. When you have a patient of trauma, I believe you have a lot, because the guys here, they use helmets in the motorcycles. So, including the kids, it's amazing. This is something my heart was a little yesterday when I saw the kids inside the motorcycles without the helmet, but that's okay. When you have a patient with the trauma surgery, and we can do the surgery in the first 20 days, 25 days, because he's in the UC or because you're not stable to do the maxillofacial surgery. So in the end of the 20 days, 25 days, what your bigger concern is about the mandible, right? Because the zygoma, if you have just a few deviation or just a few displacement, it's not be so bad. Depends, of course, the sequelas of the vision, but just about the aesthetics, it's not be so bad. But anyways, if you have a very, very, or slight, not very, a slight deviation of the mandible, everybody in the family, including you and the patient, can see the difference before and after the trauma, because the mandible changed the position. You have the changes of the anatomy of the mandible. So it's the same in orthognatics. We also learn from the older professors. We must to planning the position of the maxilla, and then you're going to put the mandible in the final position. But who is the call? the call is put the maxilla in the right position. This is true, but we must looking for the mandible. We must looking for how is the end of the mandible. Because of that, we can plan in the final position of the maxilla. After that, so here's the patient prior to surgery and after the surgery. It's my last patient, class 2, and she have everything. She have a deviation of the midline, she have a deviation of the lips, class 2 position, gun smile, so the entire package. We go to the virtual planning one more time. We're gonna do always the same thing. We're gonna put the maxilla up, the counterclockwise rotation. So we have -7. In the end, I have -4 almost. So I can put the mandible forward a little bit and then the chin forwards as well. Here is the mandible prior to procedure. There is a very important asymmetry, and here is the mandible in the end. So I have the alteration of the yaw. I move the yaw in the counterclockwise rotation, exactly to provide a better position of the mandible. The advance of the mandible, including, is asymmetric. It's pre-ops and post-ops. So, class 2 patients are very difficult for sure. In my hands, it's more difficult than class 3, but also we have a few class 3 patients. They are a challenge as well. So, you have any questions about class 2 patients? Okay. One more time, smile. If you have a patient in the end of the procedure, in the end of the treatment, the smile is not so good, the patient is not happy. I go to the doctor, to the dentistry, or to maxillofacial surgeon to improve my smile, to improve my beauty when I'm smiling. So the smile is very important. The smile line is very important in my opinion. Also, in my opinion, the mandible contour and the final contour, the outline of the mandible is very important. So in the class 2 patient, it's concerned about TMJ, right? In the class 3, my concern is about airway, it's about the tonus of the lips, the muscular lips, and also the relapse of the muscles and suprayoid muscles. Most of the class 3 patients, mainly, especially for you, can receive a lot of maxilla advancement. If you do just the mandible, and the maxilla is a little bit hypoplasic, you're gonna put the mandible so behind, and the entire movement and the profile is not be so harmonic. So I believe if you can, of course, depends on how much you can, but you can use all the space to put the maxilla forward. And of course, respecting how many forward you can do that idea. And use that, you can use this advantage to bring the muscles of the mandible with you, and for sure the breath and the apnea is going to be better after the surgery. So this is a very young lady, class 3 patient. She doesn't have the right projection of the maxilla. So the idea is, of course, I'm going to put the mandible backwards a little bit, but how much I can put the maxilla forward? Okay, here is the virtual planning one more time. And I do remember the 2 things very important in the class 2 patients. First of all, the counterclockwise rotation, right? Because I want to do everything to put the chin a little bit forward. And the class 3 patient is completely opposite. I'm gonna do the rotation in a clockwise direction, okay? Because I want the chin go backwards. So this rotation is like this. I'm gonna put the molars in an upper position, and maybe the incisors in a lower position, so I bring the mandible behind just using that kind of movement. Here she had -6 in the occlusion, and I give to -8. Looks so little, but makes a lot of difference. Sometimes, including I don't have to do the chin osteotomy. And I saw so many doctors and so many times talking about how much you can pull the maxilla forward. 5, 6, 10, 7, 8. Everyone have your magic number. But they're talking about the position of the incisors or the 8-point position. And the most difficult thing is put the maxilla forward with everything together. So the maxilla usually, she does this movement. She never does like this, completely forward. She does a movement and the incisors not go so forward. So looking for how difficult will be your advanced, looking for pterygoids. Here is Victoria, pre-ops, 45 days post-op, in here, a year post-op. Why so different 1 month later and 1 year later? Because of the muscles, because of the stability of the fixation, because she started to use the muscles. She started talking better, she started eating better, she started to have, again, all the movements of the mimics in the muscular faces. So 1 year later, they are very better than before. Another patient, class 3, and here we have one more difficult situation, is the midline deviation also. So she have midline deviation, yaw rotation, deviation of the mandible, so it's almost the entire package. One more time, clockwise rotation, so the molars going up, the maxilla going forward, the incisor going down, so this is the clockwise rotation. Here's the, I always start like this when I'm talking about the class 3 patients. She had class -6, and in the end she go to the -8. So I improved the rotation of the occlusion for this patient. Of course, we must be looking for the inclination of the incisor. Of course, you're looking for how difficult will be your movements during the surgery. Sometimes you have a lot of interference in the posterior position of the maxilla as well. And here I have +4 advanced of the incisor, but sorry guys. This morning when I wake up, I open my computer with all the classes, all the videos, everything, and my computer is completely broke. It's kaput. So I lost my entire morning trying to download all the classes and videos to iPad and the flash drive and talk with the guys here, and I'm become crazy. Today at 10 a.m., I believe I have no classes. So here I'm just happy, very happy, I think about +4 in the incisor, but over there in the pterygoids I have +6. Here's the patient pre-ops and post-ops. The occlusions are much better. The occlusion are much better, but mainly the nose is better. The support of the lip is better. The reference between the upper lip and the lower lip are better. The midline is in a better position also. So it's not only about the occlusion, it's how you can manage the soft tissues and how you can manage the entire changes of the face and your orthognatic procedures. Here is the profile, pre-op and post-op, looking how the nose could be a little bit better. And we talk a little bit about the nose in the future. Here one more patient, I believe it's the last class 3 patient, and she's the one, right? She had everything. The alteration of the cant, yaw, midline, class 3, is a very difficult occlusion, and we did almost the same thing to her. So the maxilla going forward, there is a a clockwise rotation, the molars going up, incisor going down, maxilla going forward, and then the mandible just go together. The virtual, the plan of the occlusion before is less -11. In his case, I change a little bit and I bring for less -9. So Gabriel, here you do the different. No, it's because she needs. You can, of course, you can looking for the plan all the time, but depends of the patient. You must customize. Every single patient have different demands. When you're looking for anterior posterior view, we can see the changes of the cant. So I can planning the position of the canine, bilateral canine, and the molars as well. So I can bring to her a much better symmetry of the smile. One more time, the difference between the pterygoid projection and the projection of the incisors are huge. Here's the pre-ops and the post-ops here in a very, very natural photograph. Okay, but we have one more challenge, maybe the worst, the asymmetric patients, right? When I have a lot of class 2 patients. I don't know why. I believe they looked into me and said, okay, I'm class 2, I'm going to the Gabriel. I have so few patients class 3, I don't know why as well, because I really enjoy the surgery. But unfortunately, I have most of asymmetric patients than anyone else. So the asymmetric patients, we have other concerns. The main concern is about, for sure, looking for symmetry, looking for bad occlusion, and looking for some kind of stability, because we're going to do some great changes. We can have so many gaps between the bones, so we must be looking for a very stable fixation. If you have some gaps in the maxilla maybe, we must put the bone between the gap. So it's very, very important. The stability is not about the plates, the stability is about bone. In the end of the bottom line, many months later, a year later, you must be looking for bone healing. So the bone grafts are very important, mainly to asymmetric patients. I don't know here if you can use bone for bone banks. In Brazil, you can use bone banks. You can use the transplant for the other patients to that patient. So this is regular in Brazil. Works very well. If you can do that, you can use, of course, iliac crest or whatever you like. Cranial, doesn't matter, because the bone grafts are very important. And I have here a very special patient. She goes to another team because she had TMJ disorders. And the doctors over there told her she needs to go to the orthognatic surgery because she needs improve the occlusion, and because of that, she had TMJ disorders. Well, it's not Gabriel talking, it's the science. Orthognatic surgery is not treatment for TMJ disorders. Okay? Well, the best, we're talking about TMJ on Saturday, but the best treatment for TMJ, the mostly of the patient is just splints or physiotherapy. It's good enough. We did less than 10% of the surgeries in patients for TMJ disorder. Less than 10%. But very special decision is never use orthognatic procedures to improve the quality of the function of the TMJ. The joint not responds so well for great changes in orthognatic procedures, so it's adverse, okay? So she goes to the doctor thinks a little bit different by me, and suggests to her orthognatic surgery. Unfortunately, after the surgery, she becomes very asymmetric. And why? Probably during the procedure, she committed a mistake about the position of the condyle. So in the end of the surgery, she had a wrong position of the condyle. And because of that, she doesn't have the right position of the maxilla and also of the mandible. So in the end, she still have a TMD disorder, and now she's asymmetric. And my job is give a little bit better vision for her, give to her a little about the symmetry, and then after all the stuffs, maybe think about the TMJ, unfortunately. So, you go to the virtual planning one more time. First, change the midline. Put the midline in the right position. Second, cant, the deviation of the cant. The third, the yaw. You can fix the yaw, the right position. Then you go put the maxilla forward, and then you use the rotation of the occlusion plan. So the end of all the stuffs, you have all the measure from the clinical evaluation. You go to the virtual planning, do all the measures you want, do the changes you prefer, and then you go back to the patient, trying to see if you're gonna be fine. And this patient needs a huge deviation of the mandible. So here is pre-operative and post-operative. Look, you already know how important for me is this view, right? So this is the mandible pre-operative. It's a lot of deviation of the mandible. So it doesn't matter if I made the correction of the cant. When you look in just here, you don't have the entire view and how deviation you have in the mandible. And you looking in the end, you also believes is good enough. You must go to this view to really understand how huge must be the changes of the bones to bring this patient a better position of the maxilla and the mandible. So guys, here is the deviation, very impressive. And here is a very asymmetric movement of the mandible. The right side of the mandible will go backwards, and the left side of the mandible will go forward. So this is our decision. And in the end, she must be better symmetric, mainly for the mandible. And you're looking for the maxilla, you're gonna see I do counterclockwise rotation. I change the position of the maxilla in the back to help me to change the position of the mandible as well. So the last question is, Gabriel, how much I can do these changes in the correction of the yaw? Yes, you must be looking for the position of the molars. You must be looking for how much the condyle suffer during this rotation. But if you need to do something to be most symmetric. During the surgery, I know I need a bone graft to the maxilla on the left side. So if I'm gonna do is put the chin backwards, bone I can use is the internal cortical of the chin. So I use the piezo surgery. I remove the cortical bone behind the chin. I'm gonna reserve this bone to the end of the surgery. Here's the chin in the final position. I don't need the internal cortical anymore. And here is the defect I have on the left side. The right side is already plated, okay? So I have to put the bone graft right here. Other good thing to talk to you is what plate I use first. Well, the better plate to put first is where you have bone contact. If you have a bone contact on the right side, use the bone contact to put the first plates. And the end, use the plates when you don't have the contact anymore. So here is the plates in the maxilla, and here is the bone graft. I'm a very lucky man, so the bone is almost exactly the perfect to the space. If you have a gap as well, you can change your selection of plates. Here I'm using a stronger plate to zygomatic buttress, because I really believe that we need a stronger plate when I have a gaps. In the mandible is the same. So in the right side, I have a contact, almost the perfect contact. So I can use a thickness plate, of course with monocortical screws. But on the left side, I have a gap. So I try to use a stronger plate to manage with this gap and provide a better stabilization. So here it is, slight deviation of the midline, because I changed so much the yaw. I have a very slight deviation of the midline. But anyway, the Kentis correction is good, and the facial symmetry is better. She already have paralysis of the facial nerve because of Bell syndrome many years before. So here it is. She before the first surgery, she after the first, and she after the last procedure. Oh, and now we have everything together. It's a very, very nice lady, young, 19 years old. She have everything. Is asymmetric, midline deviation, cant, yaw, and a very, very huge asymmetry of the mandible. So the idea is the correction of the maxilla, change the midline position, the correction of the cant, so the right side is going to be upper, the left side is going to be a little bit lower. The mandible go to the better situation, but the chin is still must to be treated with asymmetry. So one idea is use the position guides to the chin and position and the guides for the, of course, for all the procedures, but to the chin is a very good idea when you have a change of the entire position of the chin in the space. So it's not only backwards and forwards. You need to change the position of the chin using the cant and yaw position so a new position of the cant and yaw. So the guides would be a very clever idea. One more time, she had 0, almost 1 degree of the occlusal plan. I bring to -6, put the mandible, the chin backward, the maxilla forward, and also we have this mandible prior to surgery. And I try to reach this mandible after the surgery. Of course, maybe in the end, she still have a little bit less projection of the angle of the mandible on the left side. But if I can reach this improvement, for sure she can be better. Here is the guides for the cutting guides first, and then the positional guides for the chin. Here is the surgery. I really enjoyed the piezo procedures, using the piezo at least to make the marks. And here is the cutting guides, and here is the positional guides. The guides nowadays is very smaller than that time, but I believe it is very good. The idea use the guides when I have a new position of the chin and using the new position of the cant and the yaw of your chin. Here is the end. The chin, of course. Here's the final occlusion many years later. Here is she prior to surgery, a month later, and 6 months later. But now we're going to see her 3 years later. Changed a lot. Why change? Change because the soft tissue is better after a few years. So guys, before I show you surgery, I have a video, nice video to show to you. A few attention points. First of all, I really believe the virtual planning in asymmetrical patients is imperative. I know it's not available for most of you, or for some of you, I don't know. But nowadays, I believe the virtual planning is very, very, very important. Please raise your hand when already use virtual planning for orthognatic surgery. Is difficult to use in here, virtual
Yes.
planning?
Yes.
Yes? You still use the casts? It's very difficult to reach a better predictable results. The results could be good, but the prediction is very difficult to reach. Beware of the TMJ and when you suggest huge movements of the jaw. And for sure, always looking for internal stable fixation. We planning the final position of the maxilla because we want the finest position of the mandible. So we heard for many, many years, the main goal is the better position of the maxilla, yes. But looking for the better position of the mandible as well. Because the interference of the final position of the mandible will be very important when you choose the final position of the maxilla. So always remember the situation between risk and performance. It's our obligation looking for accident prevention, prevention of the bleeding, bed fractures, and provide a very good stable internal fixation. And when I'm talking about a very difficult movements or segmentation of the maxilla in many parts, the patient really understands what the risk is going on and what's going on and what's the risk. So how you can prevent most of the situation? Talk a little bit with your orthodontics, because maybe, just maybe, if the patient knows the difference between many parts of segmentation and maxilla and just have a second molar a little bit crossed, maybe the patient doesn't want the many segmentation of the maxilla. So you and your orthodontics must to talk a lot. As a final conclusion, is our responsibility to reach a finest result without exposure our patients to damage or unnecessary risk. Explain them what is possible and what is not, because sometimes the surgery is fine, the patient is good, but the patient looking for something different, and you can provide that for him. Prevent accidents for sure, and help them to be happy as possible. This is my picture from yesterday. Now I'm going to show you guys my last virtual planning before I came to Indonesia. This is a young lady, class 3 patient. You can look in here, the deviation on midline is very impressive, but here we have a problem. The anterior, I'm sorry. Must be different here. Ta-da. Yep. So the midline deviation is very impressive. Here's the midline. Doesn't work, I don't know why. So you see midline, right? And the anterior, the nose, the tip of the nose, and the anterior point of the nose, are in the exactly right position. So when I put the maxilla to the right, a few millimeters, like maybe 2 or 3 millimeters, the point of the nose, the tip of the nose going together. So I must do something different to respect the right position of the nose and put the midline to the right. So this is my first challenge. The second challenge is she had a slight asymmetry of the mandible. The occlusion plan is -3, and I'm looking for a little bit better in the end. Here is the end. I put to -5, so I did clockwise rotation. The maxilla go forward, and the mandibular a little bit forwards as well on the right side. And the chin is almost the same position, but a little bit upper. So here's my reference during the surgery. I must looking for not exactly the same measure, but the difference between the upper bone and the lower bone, more proximal, the bones are on the right side, more distance on the left. So it's my reference during the procedure. Here is the maxilla, a slight contact in the posterior border on the both sides, more on the right side, less on the left. So I have all this information for me during the procedure. And here, the changes of the yaw. In the end of the surgery, I have a midline in a better position. So the molars are a little bit better, but I changed the rotation of the yaw for sure to have a better position of the mandible. Look here again. So this is first, and this is the end. Change a little bit, not change so much, must change. And change because I want a better mandible contour in the end. The outline of the mandible is very important. Here is another reference during the surgery. On the right side, I have distance between the bones, something like 2 millimeters between the bones. And the left side, I have a little bit more in the upper and a little bit lower in the basal of the mandible. The occlusion pre-ops. Here's the chin. The occlusion post-ops. So I have everything to provide a most predictable surgery to this lady. And I show to the patient all this documentation before the surgery. We can have, for example, a virtual meeting. I show her everything, and then she can be comfortable with the planning. Here is my idea of the mandible. I just put a little bit upper, and I can use less than 1 millimeter. Almost the saw is sufficient to change the position of the chin. Now resume for me during the procedure, the scales of the measures, the occlusion, everything is green is good enough. This red points a little bit too close, the tooth. I can use the position when we have the mark is more than 1 millimeter, more than half millimeter. So I can use a burr to make very slight changes of the tooths, very slight. The orthodontist can hear us. There is orthodontics in here? No orthodontics? So you're good to go. No wisdom tooth. There is no consensus in literature about wisdom tooth during the orthognatics. In my experience, I have a few bad splits when the wisdom tooth are in the mandible during the orthognatic surgery. So in my preference is remove the wisdom tooth months later, months before the surgery, maybe 6 months later before. And then I will go to the orthognatics, okay? If it's possible, I believe this is the best. And here is the video of the surgery. You have a few minutes? We have. So I'm gonna show you exactly my point of view of the surgery. It's a very light camera I can use with the light, and we can see the surgery, almost everything. This is, of course, does not have 3 hours and a half, but 50 minutes is sufficient. Here is the approach of the mandible on the right side. The approach, it starts in the space between the molars and premolars, and go into a little bit behind the second molar and over the oblique line of the mandible. We can use a scalp, regular scalp, or we can use a electric, as you prefer. Here we don't see bleeding because we can do infiltration before the surgery using lidocaine with the vasoconstrictor, that's okay. The displacement of the soft tissue is very gentle. I believe this is the most important thing to post-operative care. Aftercare is very important. The patient don't want anymore. They don't want anymore huge edema in post-operative procedures. So be gentle with the soft tissue all the time. Here is my point. Until I go with the displacement of the soft tissue to looking for the better position to the osteotomy. So when I find the lower position of the temporalis muscle, I do a little bit displacement and then I can stop. So I go into here and almost in the same line of the upper molars, and then I'm looking for the mandibular foramen, where I have the mandibular nerve, and I'm trying to do my osteotomy above this reference, above the foramen. So here is the detachment of the soft tissue, very gentle, like I told you, and I'm looking for the foramen at this moment, including the retraction of the soft tissue must be very gentle as well. Okay, and then I'm gonna use a burr, a strong burr above the foramen, mandibular foramen, to bring me or to reach most posterior position of my piezo surgery. So this first burr is just to be more easier to do the last osteotomy using the piezo procedure. So here I'm gonna using the piezo. I start in the same position of the burr. I go behind the mandibular foramen, and then I go into the first molar. Okay, I leave half mandible to the left, half mandible to the right. I use the osteotomy exactly on the middle, most of the surgeons, or a lot of the surgeons, usually use this osteotomy a little bit lateral. It's better for the nerve, but it's very difficult to do without a bad splits. So when a good idea, and I start to use the piezo, I don't have to so much care about the nerve, because the piezo will be provide us slightly security about the nerve, and I can do my osteotomy a little bit on the middle of the ramus of the mandible. Is a nice idea. So the osteotomy finish exactly between the second molar and the first molar. You can use a different position. You can stop in the second molar. You can stop in the premolar, as you prefer. And my preference is between the first molar and the second. This is a very important osteotomy. Let me show you here. One step very important, I can show you better in the other side, is exactly this position. When you go vertically into the border of the mandible, this is very, very important. Then you can use a chisel just to create some space to use the spread of the Smith. 3 points are very important. Over there, up near the mandibular nerve. Here in the center, in the position of the border of the mandible. Here's the other side. I believe it's the view a little bit better. The osteotomy, the approach is the same. The class of tomorrow, I'm going to show you the same osteotomy, but in a cadaver, so I can see more. I have more space to show the osteotomy to you. And here the displacement of the soft tissue, very gentle. You can use a Minnesota here to retraction, or you can use a different retractor if you have, doesn't matter. One more time, I go looking for the temporalis muscle. In the temporalis muscle, I have maybe some half centimeter to detach, and then I'm looking for the mandibular foramen and the mandibular nerve. Look, it's exactly the same procedure I did the other side, exactly the same. If I did 200s in the morning, I did the same time, same way. Here is the detach of the temporalis muscle, and here's the burr above the mandibular foramen. Here is the osteotomy just to improve the position of the saw and go behind the foramen, behind the mandibular nerve. So here, now I use the piezo. The piezo goes including behind the mandibular foramen. And then I will go down one more time, half of the ramus in the one side and half of the mandible the other side. And this is exactly the sequence I do. I do mandible first, then I do the chin, and then I go to the maxilla, because it's faster, easier, and very, very predictable. So I'm finishing the osteotomy here. Like I told you, I go into the space between the two molars. I stop it, then I close the mouth, remove all the retraction, close the mouth, and then I can see much better the position of the saw in the border of the ramus, the mandible. So I'm finishing here, and then I change to do the vertical osteotomy with the mouth closed. You can see the piezo is very nice because it doesn't bleed it so much, right? And the people said, oh, the piezo is too slowly. It's not so slow at all, it's sufficient. Here, look at the osteotomy, it's a nice view. Oh, man. Okay, you can see, okay, all right. Here is the foramen, and the osteotomy go behind the foramen and posterior of foramen. So I completely sure about the position of the nerve. The nerve is going to be in the entire nerve is going to stay in the one segment of the osteotomy. And here is I'm doing the last part of the osteotomy. I go into the border, and the very important situation, very important moment is the border, exactly the lower border of the mandible. It's very important. To go completely, you must reach the internal cortical of the mandible in the lower border of the mandible. It's very, very important to prevent bad splits during the split of the mandible. I'm not finished yet. Now I'm finishing. I'm changed the position of the piezo to go further, to go into the internal border. Okay, now I'm finished. You can see clearly I'm go into the internal cortical. Here's the chisel. It's almost loose. You can do. You don't have to do so many use of the chisel, just to spread a little bit. 3 steps here, near of the nerve, in the superior osteotomy, horizontal osteotomy. but I already know the nerve is in the medial position. Then I will go near the molars. It's not bleeding because I don't touch the nerve, I don't touch the vessels. Okay. To reach more space, to use the Smith. Then, near the molars. Here. And we start to relaxing the inferior border. Now I go directly to the inferior border. I must feel the sizzle in the retractor. So I completely understood I'm going to the end. This is a very important moment. I always ask it to my residents, you are happy with your osteotomy? And they said, more or less. I'm always afraid. So now we're gonna use the Smith in one hand. In the other hand, I'm gonna use the overgazer, right? So there is the Smith. The Smith is always near of the molars. Here is the Smith, here is the molar. So if you put the Smith so upper in the osteotomy, you can push a little bit harder, and then you can have a bad split of the medial segment. And here, you're gonna use the overgazer. The overgazer is here. The overgazer is here, in the end of the osteotomy. The position of the overgazer is exactly in the inferior border of the mandible. So I use the both hands, I twist the overgazer a little bit, and I strangle the Smith. And I hold the Smith, not everything, just a bit. And then I push the overgaze a little bit more and strangle the Smith and do the both at the same time until I feel the, then I'm happy. I already can see the nerve here. The nerve is behind this section. I already can see the nerve. So I know the nerve is in the right position. Sometimes the nerve is attached of the other side, like in the end of the osteotomy. We can use a mold for the liberation of the nerve, no problem. And here we go. The nerve is almost on the other side. I just release a little bit here. Look, I'm using the mold to release the nerve. I can see the entire border of the osteotomy over there. The nerve is completely free. And then I will go to the fixation. Remember, osteotomy, mandible osteotomy, chin, and then the maxilla. I use the small hole here to put the mandible in the right position, to put the bone in the right position, mainly because I'm concerned about the condyle. So look the mold over there. And I use the other instrument to push the mandible backwards, to trying to put the condyle in the right position inside the glenoid fossa. And then I can use the instrument to hold the mandible in the right position, and I will go to put my plate with monocortical screws. It's a very small approach. You can use locking screws or regular cortical screws, depends on what you have. I prefer the locking screws, but I usually use the cortical screws as well. This instrument is very nice because I can hold the instrument, and protection of the lips is very nice. and I can do everything by intraoral without huge approaches. Then I already finished my plate. I will going to put the two bicortical screws in posterior position by intraoral as well. So I'm here and putting the bicortical screw. Every single time I'm choose a position when I have bone contact. This is very important because if I put the screw, doesn't matter if you don't do the technique to compression, you always provide a little bit of compression between the segments. So if you choose a place, a spot with a bone contact, you can push a little bit harder your screw and you don't have compression and you protect the condyle position. And why you put two screws? Because one screw always have a possibility of the rotation. Two screws is very stable for the fixation. My patients stay something like 30 days, a month, just eating soft diet. What is soft diet? It's everything on the liquidificador. I forgot the name of this thing, device, but like a soup. The other side is the same thing. And the screws, bicortical screws, exactly the same. And then we go to the chin. So the chin, I do a mark. I'll go back to the marks. This mark is very important because, like you're gonna see, I don't show the entire chin anymore. I do a very small incision in the center of the chin, and I'm looking for tunnelize the approach, looking for the end of the position of my osteotomy. So the approach is between the canine, the both sides, not more than that, could be including less than that. And I go directly two plans. First plan is mucosa, depois I go to the muscles and to the bone. A slight retraction of the soft tissue. I really enjoy do some marks using the piezo because I can looking for the difference between the marks and how deviation I have of the center of the chin to the right or to the left. And here I'm doing the marks of horizontal position of my osteotomy. I will not do the entire chin with the piezo because here is not strong enough. So now I'm gonna do is tunnelize the approach, reach these marks I did on the skin. So I put my finger over there and I will go with the retractor until I feel, not till I look, the marks. So then I can use the saw. I put the saw inside the barrel, inside this barrel, and then I did the osteotomy, complete osteotomy, the both corticals, until my mark, my horizontal mark I did before. My mark's here, so I bring the saw since the inferior border until the mark. And I do the same on the other side. So I can do an entire chin with the fixation in 20 minutes. It's very fast. In the end, I almost don't have to use the scissors anymore. It's all completely loose. It's very easy to go. Here I don't use at all. And to me, a small plate is very good in the chin. You can use a EMF screw to reposition of the chin. Have your assistant can hold for you. You put in the right position and then just put the plate over there. It's insufficient. If you like this patient, if you remember in the planning, I want to put the chin a little bit in the upper position. So I use the measures to realize if I have a good position as I'm planning. I'm closely
the end of the chin, I already close the muscles because I never go back here. But the mucosa I do in the end because sometimes the mucosa is, I must to treat a little bit better of the mucosa. And also, if you can see, my mouth is still close with the EMF fixation. I did the EMF for the fixation of the mandible, then I not release the fixation of the EMF, I did the chin, then I release everything, and then I will go to check if my occlusion is good. This time is very important. When you release the EMF fixation, I must to check, sorry, let's go back a little bit. When I lose the EMF fixation, I must to check if I don't have any kind of midline deviation and holding the splint in the upper position, I hold in the splint over there, and the mandible must to go to the exactly right position of the splint. This is very, very important, because if the mandible is very, very easy to go to the occlusion, so you have exactly the good position of the mandible. If you don't, what's possible it is your condyle was in the wrong position, and you must go back, release the fixation, and do one more time. So now we go to the maxilla. Not forgot to do the measures of the maxilla you wanted, the vertical position of the upper incisor, maybe the canine, or maybe the molars if you wanted. In my case, I looking for the measure of the nose as well. And then we go to the left forearm approach. And if you remember, our concerns about the position of the tip of the nose. So we're gonna do a different osteotomy here. We did sub-spine osteotomy to hold the tip of the nose in the right position. And the incision is very, very short. It's from canine to the other side, no more than that. And when you finish the surgery, it's a little bit more, but we start just with this approach here. The displacement of the soft tissue to the pterygoid is by tunnelization as well. Here is the approach, and here we're gonna do is the displacement of the soft tissues of the nose, and we're gonna do this under spine osteotomy to hold the tip of the nose in the position, the natural position for him. Just release a little bit the mucosa of the nose, very gentle. If it's possible, we don't want to do a damage in the nose mucosa. On one side and the other, and then we're going to use the piezo one more time to do this under spine osteotomy. Okay. There we go. So the osteotomy starts in the cavity of the nose, and then we go into the center of the anterior spine. Of course, we must take care about the tooths and the roots of the incisors. And you can do in the one side and then in the other. It's very, very, very easy to do. It's very easy. Okay? The beauty of this osteotomy is the entire tip of the nose stays together. You not spread anymore the septum and the anterior spine of the nose and the point of the tip of the nose as well. So everything stays together. So here is the second osteotomy. A little bit inclination to the cavity of the nose. And when you finish with the piezo, it's already released. We also don't have to use the scissors at all. Okay, we finish here. Gabriel, we use to all the patients the same osteotomy? No. It's one more tool I have to provide a customization of the procedures. Depends of the needs my patient have. So here the septum is still attached to the maxilla, but the tip of the nose is released. So here is a little bit difficult to use I know that, but I'm not open the entire mucosa anymore. I believe that this mucosa is very important to the healing. I can feel with my finger where is my instrument. I go to the end of the maxilla looking for the pterygoid junction over there, and I can feel the instrument with my finger. So I'm right, then I'm happy. So I use the saw here. Looking, this image is very nice. The saw is entire behind the soft tissue, behind the mucosa. And I put my finger and I can feel the saw over there. And I can, the backwards of the saw doesn't matter and doesn't do any kind of damage. You don't have to concern about it. And then I'm gonna start the osteotomy, and then I will go into the nasal fossa. Use the scissor in the front, like everybody else, both sides. I start with this scissor here. Okay. Then I will go to pterygoids. I use the same you do. Go with the scissor into the pterygoids, change the noise, okay, and there. And then you choose how you want to release the pterygoid from the maxilla, or the maxilla from the pterygoids. I still really enjoy using the scissor, and because of that, I have a little bit more, my approaches, I lost a little, this so little approach I started in the beginning. Here is the scissor in the septum, and I use 2 Smiths to down fracture. I don't use the hooks anymore, just 2 Smiths. I can do that. Very easy, no traumas, and very easy to do. Then here is a nice also. How I have sure I release the maxilla from the pterygoid buttress. I use this Smith one more time. Go really posterior, put the point of the Smith over there, hold the incisor with another hand, and twist. When I twist, I can see the maxilla releasing, like now. I can show you again. The down fracture. I hold my right hand with the Smith in the left side of the patient, and then I will go to the other Smith, to the posterior, and then I go more down I can in a lower position, so I'm completely sure I release the maxilla from the pterygoid buttress. I do the same thing the other side, so the maxilla will be completely free to change the position wherever you like. This is very, very important tip. The maxilla must be free, completely free. You can hold the maxilla as a, total maxilla prosthesis, must completely release in your hands. If you have slight damage of the soft tissue of the nose, this is the time to fix. Sutures here is very important to the post-op, because the patient doesn't have so many bleeding in the post-op, and is very comfortable to the patients as well. The quality of the breathing is more fast to them, so this is a very important topic. So now I'm going to put the maxilla in the final position. What's happening? I changed the position of the midline, right, the maxilla. So that position, the old position of the tip of the nose is going to be changed. So I must find a new place to the older position of the tip of the nose. So what I'm doing is a new space for the tip of the nose over here. So if my maxilla go to the right, I need to looking for a new space on the left side. I use the burr until I have a very slight or very passive position, and the nose will gonna be in the right position at all. If you want it like I want it, I really want to do, I stabilize the tip of the nose, and I did a little of traction. So I made a hole here, and another one very small in the maxilla, so I can use a suture just to put the bones in the as near as possible. Two small holes there before the fixation, because after the fixation is much more difficult. And there we go. So the midline is correct, and my tip of the nose is in the right position as well. Remember, the point I have more contact as possible, so I'm gonna put the plate first. And remember, this deviation of the bone is the same deviation I have in the virtual planning. So I'm happy because I know my reference is going right. So here I check the position, vertical position, and do another screw. There is a sequence of the screws. I always use a gauze over there behind the plate because sometimes the screws can release and you must go down to pick up the screw. It's not so good thing to do. So here's the plates. The both sides. And here's the suture of the tip of the nose. I do one more. It's just to stabilize the tip of the nose. In a few patients, I use one of the holes of the plate, but it's not so necessary. Just a suture is sufficient. This is very nice to push the tip of the nose a little bit forward and give the patient a little bit more aesthetics. Here's the nose, and then the end, the clipping, I put the entire nose in the right position. Here's the end of the occlusion, the final splint. I hold in the right position, close the mouth again, very, very exactly when I'm planning. Okay. The last suture. I'm trying to put the suture exactly in the lateral position of the alar cartilage to avoid larger position of the nose in the end. I do the same in the other side. I use the hole of the tip of the nose one more time to bring the entire nose to the center. Again, go back in the same hole.
Dr. Gabriel, I think we're running out of time. Probably we can wrap this up in a couple of minutes.
I finish in 30 seconds.
Okay.
It's 2 hours, it's 2 hours, man. I hold, and I can see the tip of the nose in the final position. Release the lips, and that's it. Okay, 2 hours. Thank you very much.